Can a CBCT be the solution to diagnosing the transverse discrepancy within orthodontics? Welcome to this episode of Orthodontics in Summary. Today's episode is a deep dive into what the role of a CBCT can be in diagnosing the transverse discrepancy. This was an excellent lecture given by Chun Hsi Chung at this year's AAO. And at the base of the problem is, what is the ideal transverse dimension? It was left out of Andrew's 6 keys. And although there's a consensus as to what the ideal transverse relationship looks like, how to diagnose and treat still remains a very debated and varied topic within orthodontics. What Chung's group's also done is to look at what is the role of digital study models, and can they be used instead of CBCTs to diagnose accurately the transverse dimension. To give an introduction to this topic, we're going to look at what is an ideal. So what is established before the use of CBCTs? The curve of Wilson. So just to recap, how the curve of Wilson is assessed is a vertical discrepancy between the buccal cusp tip and the lingual cusp tip, and it should be around 1 millimeter. Now, where CBCTs have investigated the validity of this is Alkhatib's 2017 study, have shown indeed there is a discrepancy. When it comes to looking at the upper arch, the molars should be buccally inclined by 5 degrees. In the lower arch, they are lingually inclined by 12 degrees. Another measure of assessment is looking at the alveolar ridge line. This was by Andrews back in 2000. And just to recap, this is the Bucco-lingual distance from the crown, measured at the facial access point, to the most prominent portion of the mandibular bone, which coincides with the mucogingival junction. What was hypothesized is that if this discrepancy for the first molars is 2 millimeters, then the tooth should be over the basal bone. Now, CBCT study by Glass in 2019 showed this actually wasn't the case. However, where the validity was of the alveolar ridge line was that it coincided with the center of resistance of those posterior teeth. Now, the question is, what is the average distance on a CBCT to measure the transverse discrepancy? This was Lee's study from 2022, which Chung was involved as well. This was the most recent Penn study looking at this topic. They looked at a range of values. It was an excellent study. They looked at both the buccal aspects, the furcation, the lingual aspects, and looked at what is the most reliable measurement to make on a CBCT. And they found from their study it was actually the lingual aspect which was most reliable. The buccal aspect can be misleading due to the buccal shelf that's present. The scores on the doors were: the maxilla is narrower than the mandible by 1 millimeter. However, the standard deviation of these measurements was huge at 3 millimeters. Now, there's other references that have been used in the past looking at the buccal aspects. Some have quoted 5 millimeters, when that comes to a Tamburino study from back in 2010. However, more recent studies by Lee in 2022 showed actually there's a 1.1 millimeter if we looked at the buccal aspect of the maxilla to the mandible. And that creates a picture for us that actually the maxilla seems to have more bone present, bucco-lingually, and actually the mandible has far less bone present. Can the transverse dimension be diagnosed from digital study models and not requiring the use of CBCT? Chung and his group asked this novel question. They looked at the use of digital study models and the distance to the furcation of around 4 millimeters. They then looked at discrepancy between the maxilla and the mandible at this distance over their cases and compared them to CBCTs. And they found that actually measuring from the lingual aspect, 4 millimeters below the gingiva, on the digital study model, the mandible was wider than the maxilla by 2 millimeters. Again, the maxilla seems to be the narrower arch. However, again, the range of values, the standard deviation, was 3 millimeters. So in conclusion, the CBCTs have demonstrated that the maxilla is narrower than the mandible slightly when measured from the lingual aspects, but the range of values were so significant. And this has been shown in other studies as well by Miner, who described a 1 millimeter discrepancy, but again a 2.9 millimeter standard deviation. What does that mean? Well, it means that any range of values from -4 millimeters to +2 millimeter discrepancy between the maxilla and the mandible falls within this standard deviation. I think the range of values are just too significant at this stage to be clinically useful for its application. Once more, what treatment modality is then indicated, and how much within this range do we need to get our patients to resolve this discrepancy? I would still state at this stage, the use of the Weilar ridge line and the curve of Wilson still indicate clinically to us where things lie and are parameters that we can work towards when it comes to our measures of assessment. I hope you've enjoyed this episode of Orthodontics in Summary. Please do subscribe and look forward to the next episode.